in child-aging head injury patients and in determining the urgency with which they must be evaluated and treated. A GCS score of 8 or less has become the general accepted definition of a comatose patient. Primary signs and reactivities are also essential components of the initial neurological examination. The presence of an unresponsive pupil, particularly a dilated pupil, is significantly correlated with poor outcome and therefore an important part of the examination. Hypoxia, hypotension, and alcohol or drugs may all contribute to abnormal neurological examination. In addition to for the diagnostic procedure, in addition to the abbreviated medical history and physical examination, imaging of the brain is an important method of evaluation of these patients. CT scan is clearly the procedure of choice in evaluation of TBI patients. For acute evaluation, CT scan a CT scan has much greater efficacy than plain scar films or MRI. It's strongly recommended that an emergency CT can be attained as soon as possible, preferable within half an hour after admission with a severe head injury. And the CT scan can assess the presence or absence of fracture, epidural or subdural hematomas, intracerebral hematomas, and concussion, shift of the midline structure, and the appearance of the basal or perimesencephalic systems. While for the plain scar films, it can provide less information. And from this CT scan of the head in a patient with closed head injuries, we can see the severe compression of the mesencephalic system indicate midbrain compression. And this is the CT scan of a patient with closed head injuries. The patient has a right temporal epidural hematoma. This mesencephalic system are patent, indicating a lack of brainstem compression despite mass. And this is a CT scan of a patient with closed head injuries. This patient has suffered an acute subdural hematoma. We also can see the midline shift. The evaluation of the patient with severe head injuries during the acute stage relies on rigorous and frequently monitoring of the patient's neurological examination, GCS score, pupils, pupils, arterial blood gases, and in most cases, ICP. In general, all patients with GCS of 8 or less have ICP monitor placed. There are two types of ICP. ICP monitor device can be considered. ICP monitor can be considered for two types. The first is intravesical catheters. Another is devices that measure pressure from sides other than the ventricles. For example, brain parenchyma, subarachnoid, or subdural or epidural space. This picture shows how the doctors put intravesical catheters, and this is the monitor. The ventricle catheter is generally preferred because it's assumed to be the most accurate, and the CSF can drain to decrease ICP. Other methods of invasive monitors include the measurement of jugular venous gases, brain temperature, oxygenation probe, and brain microdilate, and brain microdialysis. Then how can we treat TBI patients? Prompt physiological resuscitation is the first priority. 前面这句不要吧。The patients are significant of the first thing we should do is to restoration of the blood pressure, oxygenation, and ventilation. A patient with a significant clot or contusion should be taken to the operation room for evacuation, provided there is no severe coagulopathy. When no operative lesion is found by CT, which occurs in approximately 70% of cases, the patient is treated by medical treatment, primarily directed at normalization of ICP. The goal of control of ICP is try to keep ICP less than 20 mm high charge room and to maintain cerebral perfusion pressure at or above 70 mm high charge room. The following is the simplified algorithm. The following is the simplified algorithm for the management of intracranial hypertension. The head of the bed is elevated to 30 degrees, with the head placed in a neutral position. This maximizes cerebral venous drainage via jugular vein. Care is taken to ensure that any cervical spine immobilization device is not obstructing jugular venous flow, because care is taken to ensure that any cervical spine immobilization device is not obstructing jugular venous flow, because this can increase ICP. CSF drainage is now the first line of therapy in decreasing ICP. This is accomplished by an external ventricular drainage or ventriculostomy. Mannitol and other diuretics mannitol and other diuretic agents. Mannitol is administered intravenous bolus of 0.25 to 1 gram per kilogram body weight every 2 to 4. Mannitol and other diuretic agents. For the mannitol and other diuretic agents, mannitol will treated intravenous bolus of 0.25 to 1 gram per kilogram body weight every 2 to 6 hours. Other diuretics, for example, furosemide, also can be used, but it's important to maintain U volume to keep to. It's important to maintain U volume. It's important to maintain euvolemia to keep the cerebral perfusion pressure. It's important to maintain U volume. It's important to maintain euvolemia to maintain the cerebral perfusion pressure. Hyperventilation. For if ICP is elevated, if ICP is still elevated, judicious use of hyperventilation is. If ICP is still elevated, judicious use of hyperventilation to pressure of carbon dioxide of 30 to 35 millimeter hydrogen may be used. Hyperventilation causes are decreased. Hyperventilation causes are decreased in ICP by lowering pressure of carbon dioxide, which causes vasoconstriction and decrease intracranial blood volume. Unfortunately, this also causes decreased cerebral perfusion. Hypothermia is benefit in control ICP, referred to other therapies. It was thought that the primary mechanism of action of temperature control therapy was reduced in cerebral metabolic rate. There is no evidence that mild hypothermia might also include excessive post-traumatic release of excitatory neurotransmitter and attenuate the opening of brain and attenuate the opening of brain barrier and attenuate the opening of blood-brain barrier. There are also other second-tier therapeutic intervention. When ICP becomes refractory to these strategies, RCT scan is mandatory, particularly if mannitol dosage has been optimized to look for newly formed or expanded mass lesions. In case with new mass lesions, then the operation is needed. While in case without new mass lesions, second-tier therapeutic intervention included hypertonic saline high doses barbiturate therapy or even decompressive cranial or even decompressive cranioectomy could be performed. Energy requirements after traumatic brain injuries are increased. The non-paralyzed patient requirement placement of 140% of their resting metabolism expenditure. For the paralyzed patient, and the paralyzed patient required 100%. Feeding begins within 7 days after trauma. Steroids have no proven benefit in management of TBI patients and are not used. Prophylactic use of anticonvulsant agents. Prophylactic use of anticonvulsant drugs is not indicated for the prevention of the late post-traumatic seizure. Anticonvulsants may, however, be used to prevent prophylactic use of anticonvulsant drugs is not indicated for the prevention of late post-traumatic seizure. Anticonvulsants may, however, be used to prevent earlier post-traumatic seizures, and usually after 1 week of therapy. For the operative management, when the workup of a patient reveals are intracranial lesions and the deficits thought to be related to the lesion, operative intervention is indicated. Cause of contusion larger than 25 to 30 cc are generally considered to cause significant mass effect capable of causing neurological deficit. And 前面这段不要了。Cause of contusion larger than 25 to 30 cc are generally considered to cause significant mass effect. Cause of contusion larger than 25 to 30 cc are generally considered to cause significant mass effect capable of causing neurological deterioration and progressive brain injury. In general, any clot or contusion greater than 30 cc is thought to be operable. It appears that outcome has improved since the middle 1970s. From this review, we can see the mortality decreased. And the mortality rate has decreased from approximate the mortality rate has decreased from approximately the mortality rate dropped from about 50% to about 30%. The mortality rate dropped from 50% to about 30%. We also use Glasgow Coma Out Scale to assessment the prognosis of TBI patients. It includes good recover or moderate disable or severe disabled or vegetative, some patients will die. This is the algorithm for management of mild head injuries. And the risk factors include ambiguous risk factors include ambiguous accident history, continued post-traumatic amnesia, retrograde amnesia more than 30 minutes, clinical signs of skull fracture, headache, vomiting, focal neurologic deficits, and about 3%. However, about 3% of patients deteriorate unexpectedly. However, about 3% of patients deteriorate unexpectedly and can become neurological devastated if the decline in mental states is not noticed earlier. Patients with moderate head injuries may be confused or somnolent, but still able to follow simple commands. CCS is 9 to 12. And about 10% of patients will deteriorate. And so if the patient stops following simple commands, repeat CT scan and management should be considered. While for the severe head injuries, the patient is unable to follow even a simple command because of impaired of consciousness. Also, severe head injuries is only a relative small part of the overall head injuries picture. Surgeons are more involved in care of patients with severe head injuries, where the care is obviously more complicated and the risk of dying and severe disability is much greater. For the skull fractures, the pattern of skull fractures is for the skull fractures. Skull fractures are classified in 3 ways: by pattern. It can be classified as linear, comminuted, depressed, or by anatomic location. It can be classified as broad convexity or base, or by the skin integrity. If the O-line skin skull fracture can be classified by pattern, by anatomic location, and by the skin integrity. By the pattern, it can be classified as linear, comminuted, depressed fracture. By anatomic location, it can classify as broad convexity or base fracture. And by skin integrity, it can be classified. It can classify as open or closed. A skull fracture can be classified as open or closed by the presence or absence, respectively, of an overlying scalp laceration. In addition, are fracture extending to the skull base with violation of the paranasal sinuses or middle ear or middle ear structure. It also considered an open fracture. The pattern of skull fracture is affected by two facts: the force of impact and the ratio of the impact force to the impact area. A linear fractures results from a point of weakness when the skull structure fails to undergo further elastic deformation as a response to impact. The fracture typically starts at a point of weakness. In response to the maximal stress, the point of weakness is often removed from the point of acute impact and tends to the point of impact. A comminuted fracture results when impact force is sufficient to break bone into multiple A comminuted fracture results when impact force is sufficient to break the bone into pieces under the point of impact and further through area of weakness. With even larger impact energies, the comminuted pieces can be driven inward to create a depressed fracture and may penetrating the dura and injure to the cortical surface of the brain. The second factor is the ratio of impact force to the impact area. If the impact, even when of high energy, is dispersed over a large area, as in a blunt head injury to an individual wearing a motorcycle helmet, it often produces no skull fracture, even though the brain may be severely injured. However, if the impact, even one of the low energy is concentrated in small area, such as from a hammer blow, it often produces a small depressed fracture with multiple linear skull fracture radiated. However, if the impact, even one of low energy, is concentrated in a small area, such as from a hammer blow, it often produces a small depressed fracture with multiple linear sculpture. However, if the impact, even one of low energy, is concentrated in a small area, such as from a hammer blow, it often produces a small depressed fracture with multiple linear skull fracture radiated at the site of impact. A linear skull fracture is a single fracture line that goes through the entire thickness of the skull. CT skull provides more information than the plain skull. CT scan provides more information than the plain skull film. We can see the fracture here. And from CT, we can see the fracture here. the patient's eventual neurological outcome depends largely on the brain injuries rather than on the presence of a fracture. Linear skull fracture requires no stabilization or exploration when the scalp is closed, and when there is no evidence of epidural hematoma or underlying dural or cortical injury. Open linear fractures are debrided of foreign material, devitalized soft tissues, and bone fragments.